Welcome, everyone. I'm Sarah Brond, and thank you for joining us today for this Journal of Clinical Psychiatry webinar. We're excited to welcome our featured speaker today, Dr. Kristina Deligiannidis. An extremely accomplished clinician and researcher, Dr. Deligiannidis serves as Director of Women's Behavioral Health at Zucker Hillside Hospital and is Professor of Psychiatry, Molecular Medicine, and Obstetrics and Gynecology at the Zucker School of Medicine at Hofstra Northwell. We'll get started with a presentation from Dr. Deligiannidis, and that will be followed by a short Q&A. You can submit your questions using the Q&A feature at the top of your screen, and a recording of the webinar will be available on YouTube in the next few days. Dr. Deligiannidis, thanks so much for being here, and I'll turn things over to you at this point.
Thank you so much for the opportunity to review our publication in Journal of Clinical Psychiatry. And today I will give a brief overview of postpartum depression pharmacotherapeutic development from that lens, and then share data from a single-arm open-label phase 2A clinical trial of GH001 Mebufotenin in postpartum depression, or PPD. I'll share data on the main antidepressant effects, safety, maternal functioning, and breast milk concentrations and mebufotenin, all of which are clinically important in the patient population I treat, women with postpartum depression, and important considerations also for postpartum women who are lactating. So we will get started. I have the following disclosures relevant to this presentation. I serve as a research consultant for GH Research, the sponsor of this study, and I have additional disclosures as listed here. My research is funded federally by the NIH and by the state in New York, by the Office of Mental Health and the Department of Health and other sources that are listed here. So to set the stage, peripartum depression, which is a major depressive episode with onset either in pregnancy or up to 4 weeks postpartum, as defined by the DSM, or in pregnancy up to a year after delivery, as defined by the American College of Obstetricians and Gynecologists, is one of the most common complications of pregnancy and the postpartum period, affecting up to 1 in 4 women. The APA, ACOG, the American Academy of Pediatrics, and the USPSTF, they all recommend universal depression screening during pregnancy and in the postpartum period. Yet the treatment cascade remains problematic. For a hypothetical cohort of 100 postpartum women in the US, approximately 20 will have peripartum depression, so either with an onset pregnancy or after delivery. And of those, US data suggests that only 10 to 15 will be screened, 6 to 10 will receive a diagnosis, 4 to 6 will initiate treatment, and only 2 to 3 will receive adequate treatment in terms of dose and duration. We have decades of data that show the consequences of undertreated or untreated peripartum depression, and those are significant. They include adverse obstetrical, maternal, and infant developmental outcomes. And unfortunately, perinatal mental health disorders more broadly, but also including major depressive disorder, are the leading cause of pregnancy-related death in the United States and also other countries as well. Critically, maternal morbidity review committees across 36 states in a CDC report found that 100%, every one of these deaths from suicide or overdose were deemed preventable. So I want to present to you in our short time together that this is the clinical reality that motivates me as a physician scientist, my research, and the development of novel rapid-acting treatments for this patient population. So as a background, serotonergic antidepressants, mainly SSRIs and some SNRIs, have been the mainstay of pharmacologic treatment for moderate and severe postpartum depression. I cite a Cochrane meta-analysis of 11 postpartum randomized controlled trials, and they showed that there's a possible benefit of SSRIs over placebo. And the response rates that they report by doing that analysis of the studies to date were of approximately 55% versus 43% for response, and remission rates were about 42% versus 27% when measured at 5 to 12 weeks of follow-up with those SSRIs. And the reason why the authors noted that serotonergic antidepressants may show benefit is that the pooled risk ratio confidence interval included 1. So they couldn't conclude that there was a statistical difference between SSRIs and placebo in response or remission. The reality is that the majority of patients with postpartum depression receive serotonergic antidepressants in the community. And we do find that they're helpful for a subset of women. Generally, we find that combining the serotonergic antidepressants with psychotherapy improves outcomes and really is the first step for mild postpartum depression and any subsequent severity of postpartum depression. We initiate antidepressants typically when the depression becomes more moderate or is severe. From a lactation safety standpoint, most SSRIs and some SNRIs are associated with low passage into the breast milk. And so we have robust data supporting this. Those relative infant doses, sort of a metric of the dose, the percentage of the maternal dose that's weight adjusted for the infant, those relative infant doses or RIDs are well below the accepted 10% threshold, though there are some outliers. So with the sort of the landscape, that was in place when I started doing this 17 years ago, there are still important limitations of continuing down this path. 86% of patients report at least one side effect with SSRIs, and over half report bothersome side effects. Perhaps the most concerning from a public health standpoint is that 63 to 76% of women discontinue their SSRI treatment at least once during the year following their PPD diagnosis, with over a quarter, up to 38.5%, discontinuing SSRIs within 60 days. So you imagine the scenario where we don't catch everybody with screening, and when we do catch them, they're not necessarily referred to treatment. When they connect to treatment, they may not get adequate dose or duration of treatment, and then the treatments are not fully effective for those who do adhere to them. This really underscores the need for treatments that work faster, are more efficacious, are better tolerated, and require shorter treatment courses. And so that brings us to the development of neuroactive steroid antidepressants. It's going to be a little historical. It's not that long of a history, so it won't be that long. So we've had 2 neurosteroid GABA A receptor positive allosteric modulators that have received FDA approval specifically for postpartum depression. Brexanolone was approved in 2019 and is bioidentical to allopregnanolone, which is made in the brain. It's made in the periphery, in the ovaries, the adrenal glands, the placenta, the testes, and was administered as a 60-hour IV infusion. In the pivotal trials that we conducted, 72% of women achieved response and 61% achieved remission by the end of the infusion. However, brexanolone was withdrawn from the clinical market in early 2025 due to the logistical challenges of a 60-hour supervised infusion, but also the FDA approval of zuranolone in 2023. So zuranolone, which you can see on the right side of this slide, is a synthetic derivative of pregnenolone, and it's administered orally as a 14-day treatment course at 50 milligrams nightly. In the Skylark trial, 57% of women achieve response and approximately 27% achieve remission at day 15. So that was measured the morning after their final course because it's a 14-day course. Notably, the median time to first HAM-D response was 9 days with zuranolone compared to 43 days with the placebo group. And both medications, both brexanolone and zuranolone, showed relative infant doses below 1% in the breast milk. So this is comparable or even lower than what we see for published relative infant doses of the SSRIs, and certainly lower than what we see with some of our SNRIs. So these FDA approvals represent what I think, and I've been doing this work for many years, all of these clinical trials in conjunction with our federally funded work looking at how neuroactive steroids are involved in the pathophysiology of perinatal depression and through brain imaging work and steroidomics. So I'm a little impartial, but I think this really is a paradigm shift in our understanding and in the treatment of peripartum depression. But there remains a clear unmet need for treatments that are more rapid acting, that have higher remission rates, and that offer shorter treatment durations. We're just going to get better. We're going to keep doing more for the women who need it. So there are a couple of investigational agents that are currently in clinical development for PPD. And I just want to briefly highlight two before turning to our study with GH001. LPCN 1154A is an oral formulation. It's a neuroactive steroid, and it's designed to achieve bioequivalent blood levels to IV brexanolone with a 48-hour at-home treatment course. The phase 3 trial's primary endpoint of change from baseline in the HAM-D, the Hamilton Depression Rating Scale, at hour 60 was not met when including all sites. However, after exclusion of an outlier study site, an outlier on many standpoints, the data showed rapid antidepressant effects with a median time to response of 2.6 days compared to 34.7 days with placebo. And those effects persisted through day 30. We recently presented these data at ASCP this spring. Or is a synthetic serotonin 2A receptor agonist, a prodrug, which is converted to an active compound that is a structural analog of psilocin, but with a shorter psychoactive experience of approximately 2 to 3 hours. This in the study was administered as a single subcutaneous dose. And that phase 2 trial met its primary endpoint of significant change from baseline on the MADRS at day 7, with approximately 70% of participants in remission by day 7, sustained through day 28. These data were presented in January at ACMP. Now, both agents are non-approved investigational compounds. I put that bar in the upper right-hand corner as a reminder whenever I'm speaking about investigational compounds. So this brings us to GH001 or 001, the subject of today's presentation and the article that was recently published in the Journal of Clinical Psychiatry. So GH001 is a synthetic form of mebufotenin. It's also known as 5-MeO-DMT, and it's formulated for pulmonary inhalation. It's vaporized. It is a non-selective serotonin agonist with high affinity for the 5-HT1A receptor. So different than some of the other psychedelics or the RE104 that was recently tested in PPD. What distinguishes GH001 from other psychedelic-based therapeutics in development is what I think is a remarkably short duration of psychoactive effects. So the median is just 11 minutes. And this has important practical implications for clinical administration, particularly in the patients I've been working with for the past 17 years in a postpartum depressed patient population, where lengthy supervision of potential future psychedelic sessions may represent real barriers to access. And I hope to speak about that a little bit later as well. So GH001 has been well tolerated in early stage trials, and it's shown potential to induce rapid remission of depressive symptoms across 3 target indications. It's been tested in TRD, which is treatment-resistant depression. I'm going to only talk about the PPD today, and then it's also been tested in bipolar II disorder with a major depressive episode. The phase 2B has been completed for TRD, and the phase 2A has been completed in both PPD, which I'll talk to you about today, and bipolar II depression. So let's discuss the data with GH001. Again, this is a phase 2A single-arm open-label trial in PPD. So this is our trial design. After screening and a pre-dosing day, patients receive GH001 on day 1 using an individualized dosing regimen or IDR. So I just want to take everyone through that. And so on day 1, and I don't know if you can see my cursor, you might not be able to, but if you can find on the x-axis where we have day 1 and you see BL for baseline, you see it go up to dose 1. And so each participant received the first dose, 6 milligrams of the GH001, and the administration of a second or potential third dose of GH001 in the IDR was based on the patient's subjectively reported psychoactive effects. That is, if they achieved a peak experience of greater than or equal to 75 on the psychoactive experience scale, and if the dose was well tolerated as determined by the trial physician. So that if a participant did not achieve a peak experience and the dose received was well tolerated, Then after a 1 hour interval, they could receive the next dose, which would be 12 milligrams. Again, if they did not achieve peak experience with that dose, and that dose was well tolerated, then they would be eligible after a 1 hour interval to receive the final 18 milligram dose as part of their individualized drug regimen. And so we assessed MADRS total score, also PK data and safety assessments at baseline, and then at multiple time points throughout the dosing. I'll introduce you to the Barkin Index of Maternal Functioning, or BIMF. That was assessed at baseline and day 8. I'll tell you more about that. It's something we use quite often in perinatal mental health research, especially in depression research. Importantly, while research staff provided standard education and support should a participant have a challenging experience, there was no psychotherapeutic intervention. There was no psychotherapy that was given either before, during, or after dosing. So these are our eligibility criteria. They included adult females between the ages of 18 to 45 with a major depressive episode with peripartum onset diagnosis confirmed by the MINI and following DSM criteria. Patients had to have given birth within the past 12 months. So the way this works is that the episode onset, we have to, as part of the research team, is to determine that the onset was in gestation or within 4 weeks of delivery. But participants can present to research up to 12 months postpartum. We know that they present late to clinical care and also to research settings and maybe had a duration of this major depressive episode for many months before they present for clinical care. Those participants had to have a MADRS score of greater than or equal to 28, indicating moderate to severe depression. And patients could not be on an antidepressant at the time of the study entry and had to have ceased breastfeeding at screening or agreed to give breast milk to their baby more than 24 hours after that last dose. And this is because there really was no breast milk PK data in humans before this study began. And so we wanted to, it was very important to assess that in a sub-study, and I'll take you through that data as well. So patients were medically stable and very similar to the other PPD trials we have designed in other therapeutics that excluded patients with psychotic disorder, bipolar disorder, or active substance use as well. So our key assessments were the MADRS, which is a clinician-rated scale to address depression severity. Scores range from 0 to 60, and a higher score indicates more severe depression, with remission defined as a score of less than or equal to 10. Second, we use that Barkin Index of Maternal Functioning, or BIMF. So many acronyms used commonly in the work I do in perinatal depression research, which is a 20-item self-report measure specifically designed and validated to assess postpartum functioning, with scores ranging from 0 to 120. Here, the higher scores indicate better maternal functioning. We also conducted PK assessments of mebufotenin and its metabolites, bufotenin, and 5-MIAA in breast milk using liquid chromatography and tandem mass spec, and we measured safety throughout. So these are the key demographics. In this proof of concept study, we had 10 postpartum women, mainly white and not Hispanic or Latina, enrolled from sites in the UK and the Netherlands, as at the time, the IND was not available in the US when this study was actively enrolling. The mean duration of the current depressive episode was approximately 30 weeks or 7.5 months. And the average MADRS, or the mean address rather, was 36.7. So indicating severe depression, but also including women with moderate depression. And the mean BMIF was 68.8, which is impaired. So here are our data. Primary results show the significant reduction in MADRS total score from baseline to day 8. There's a rapid decrease in the MADRS scores following administration of GH001, with a mean change from baseline significant each time point. That's at 2 hours, day 2, and day 8. All 10 patients achieved depression remission at day 8. And this slide, though the lines overlap, I promise there are actually 10 colors and shapes and lines and trajectories. It provides a more detailed view of the individualized patient MADRS total scores at each assessment point. They're just really on top of each other, so you really can't discern them very well. But you can see that each colored line represents one patient's trajectory and that they each showed substantial improvement. Again, they came in around 37 and they had a mean reduction from baseline of 35.4 points on the MADRS at day 8. So in addition to the depressive symptoms we measured, we were very interested in maternal functioning as measured by the BIMF. Again, working with this patient population over so many years, the functional impairment is so clear. Not only is the patient's impairment for taking care of herself and taking care of her activities of daily living, showering, eating, caring for herself, you see the challenges that they're having, putting everything they can to taking care of their infant, but really struggling to care for their infant or their other children. And so this slide shows, and it measures those sorts of things. It shows a significant improvement in those BIMF total scores from baseline to day 8. So we saw an improvement of 34.1 points. This is a 56% improvement in maternal functioning with GH001 administration. And that BIMF, it measures a bunch of domains, so things like self-care and mother-child interactions and psychological well-being and social support adjustment. We saw across the board in 6 out of the 7 domains, we saw this improvement. So suggesting broad benefits as reported by the patient, but benefits that are important both for mother and infant well-being. And then a key consideration for any medication used in lactating women is its presence in breast milk. We know that there's any ambiguity of the presence in breast milk or the safety in breast milk, that will be a no-go for women who, for many women that are lactating and breastfeeding and are seeking and require antidepressant treatment. So this slide shows the rapid elimination of mebufotenin and its metabolite 5-MIAA from breast milk. The metabolite bufotenin was below the level of quantification with liquid chromatography tandem mass spec. So this was a sub-study, so it is a small sample. It's 4 out of the 10 women that were in the study. And in those 4, 3 had received the GH001 at doses of 6 + 12 as their IDR, and 1 participant had the 6 + 12 + 18 for the sub-study. So as you can see, both mebufotenin and its metabolite were below the level of quantification by around 8 hours post-dose, and that indicates fairly rapid elimination from breast milk. And as I said, something that's so important as we think about novel therapeutics, we want to minimize infant exposure and facilitate treatment for women choosing to include an antidepressant as part of their postpartum depression care routine. So regarding safety, GH001 was generally well tolerated. The most common treatment emergent adverse event was headache, and that was in 5 out of 10 women. All TEAEs were transient and resolved without intervention. And there were no serious AEs or discontinuations due to AEs. No patients withdrew from the trial. All patients were assessed as ready for discharge within the same day. And so really it was just a matter of kind of getting the assessment done so that they could go home because the clinical assessment of discharge readiness, it was already clear for discharge, but we had to get through the other study assessments before we could discharge them, but they were ready for discharge. So this really suggests a safety profile that allows for a brief medical supervision or intervention. These safety findings, again, I could just keep thinking about my patient population for postpartum women, just really important for those women, important for all of our patients, but especially for those caring for infants and who really struggle with having childcare. Many of these women do not have support at home, and to have something that is rapid and that they can return to the home quickly is an important consideration. So just in conclusion, our open label phase 2A trial in a preliminary way shows that this GH001 administered as an IDR is associated with rapid antidepressant effects in women with PPD. All patients achieve remission by day 8 with significant self-reported improvements in maternal functioning across many of those domains we talked about. Importantly for breastfeeding mothers, mebufotenin and its metabolite were rapidly cleared from the breast milk, was generally well tolerated. And these findings, it's a proof of concept study, right? They suggest that GH001 may represent a promising treatment option for PPD, addressing both symptom reduction and functional improvement while minimizing medication exposure. There are limitations, right? It's a very small sample size. It's 10 individuals. There's a short follow-up period of 1 week. There's no control arm. There's no blinding. And so that's, we need randomized control trials with a comparison. We need it to determine true treatment effects and true safety profile. So although they're preliminary, I just want to end that They represent exactly the direction of the field that needs to move toward treatments that work within hours or days rather than weeks, that allow women to return to their families the same day and prioritize not just symptom reduction, but for women to engage fully in their life. So with that, I'll thank you for your attention, and I just want to go over and check the Q&A to see what we have here from our audience. So let me see if I can do this more. So yeah, so there's a question here. Are any of these novel therapeutics being considered in perimenopause, since we have significant drop in hormones and many times that period can present similarly to someone's postpartum experience? Yes, I think we're leading the field, leading the charge in postpartum in these neurosteroid modulated depressive episodes. But yes, there's significant interest in developing some of these therapeutics. I think the neurosteroids will be first to go, but I hope that the perimenopausal depressive disorders are also going to be key areas of focus in the future for these therapeutics, as we think about unique periods across the female reproductive cycle where women are at heightened risk for developing major depressive episodes, likely due to a neurosteroid-based mechanism. And that may differ across the peripartum period or the perimenopause, but thus there might be a stronger biological or biotype that we can target with some of these interventions. And then we might have time for one more question. So how do we see GH001 fitting into the evolving treatment landscape for PPD alongside zuranolone and some of the other options that may be available, and how to counsel? So this is a question I think we're all thinking about, and it's really exciting to be even in a position to discuss a treatment landscape for PPD rather than simply defaulting to SSRIs and hope for the best, right? You know, when I started doing this 17 or so years ago, that's all we had were the SSRIs. And then, you know, within a couple of years, I was already starting to do some of the neurosteroid interventional work. But to be here now, we've moved to a future where treatment selection for PPD is going to be informed by illness severity, patient preference, breastfeeding status, practical considerations around treatment duration, setting, and our work, our federally funded work, is moving to treatment predictors, right? We need to move this into a personalized depression treatment algorithm space. Right now, zuranolone is the only FDA-approved option for PPD, and that it's a great option. It offers a 14-day at-home treatment course. For many women with moderate to severe depression, it can be the first-line rapid-acting option. LPCN 1154A, if it moves forward, again, talking about investigational agents right now, could offer an even shorter 48-hour oral course with a brexanolone equivalent pharmacology. For the psychedelics, at least right now, we've got GH001, 001, and RE104, and that's a completely different therapeutic class, right? So these are serotonergic psychedelic-based compounds. These could offer a one-day or single-dose treatment paradigm with rapid remission. And so, you know, for today, it's really to discuss, what I can do today is discuss our FDA-approved options. So we have zuranolone, and we have the, you know, the SSRIs that are FDA-approved for MDD, and we have a rich evidence base for psychotherapy. So it's really talking about the expected time to response, side effect profiles, you know, risk benefits of each of those, plus or minus breastfeeding considerations, treatment durations. And for those interested in participating in our clinical trials, talking about those options as well. But we're building a toolkit and not a single solution. So we want to match these treatments to individuals' needs and preferences to each woman and her family. So that's what gets me really jazzed and excited about the work we're doing in this space. And I think those are all I have in the chat or in the Q&A. So yeah, so thank you so much for attending today. And Sarah and others, I don't know if we have any other closing remarks or...
Thank you so much for sharing your time and expertise with us today. I know this has been really valuable for our audience. And thank you to everyone that joined us. We'll post a link to the recording on our YouTube channel, and we look forward to seeing you at future events. Have a good rest of your day.
Thank you, everyone.